Hey, it's me, Jen again, and today we'll meet the first endocrinologist in Brooklyn to perform thyroid RFA. We'll meet Dr. Saka Kazeem coming up. In addition to being prepared for RFA through many years of experience of ultrasound and fine needle aspirations, Dr. Kazeem also participated in RFA training in both Italy and Brazil. He offers a great deal of experience and dedication in the field of endocrinology. Tell me a little bit about why you adopted RFA and how you came to even really discover it.
So I've been really doing what you would call clinical interventional thyroidology for years, since the 90s. So I keep abreast of course, latest technologies and advances. So we've been following this and research that's been going on in using what we call thermal ablation techniques, which includes other like microwave, high frequency ultrasound, and of course RFA. So it's been going on mostly really pioneered by South Korea and then Italy and then of course Brazil also. So and I've always attended some of those conferences and tried to master those techniques in Europe and then in Brazil. Been looking forward to approval in US for this, for the approval. So when it was approved, so we just started planning and doing it. Yeah. Mm-hmm. So it's a long time coming that we know for sure that this is a technique that not everybody should really go for surgery. The default to do surgery. And then once we see that our colleagues all over the world are doing it very well, so we're just praying that they approve it. So when it was approved, I just embrace it.
Absolutely. It seems to be more widely adopted now than the entire time that it's been FDA cleared. It's kind of snowballing in effect. And I'm happy to see that. But I also want to make sure patients understand, these doctors that are newly adopting it, they need the skills and the practice, which is what you were talking about in these different areas where it's really being taught. So tell me a little bit about your training experience when you were learning how to do this procedure.
You have to learn how to use ultrasound. It's an ultrasound guided technique. You really have to be doing fine needle aspiration or biopsy under guidance, well established in that and comfortable in that procedure. Because if you don't know how to do that, you cannot just start doing this procedure because you have to know how to navigate a small area of the neck with some important structures, your vessels, your nerves, your breathing pipes, and your swallowing areas and all that. Once you can master that very well with safety and you're confident in identifying the needle tips, because you always have to know where the needle is when you're doing the procedure to make sure it's in the right place, not only when you do biopsy, but when you are going to do RFA. If you are confident in that and you have good results and your dexterity in terms of your hands is good, you can hold small things in a small area, you can then think about transitioning to an ablative procedure like RFA. You can't just say, I want to do RFA. You have to be doing intervention first, and especially FNA with guidance. So that's a key. So if somebody can do that very well and doing it over the years, then there are places where you can start practicing with either a phantom, like a cadaver-like neck, so that you can actually see all the structures, just like when we were in anatomy school and all that. So you can actually see how the necks look like, and you can move your needle and the ultrasound, so you can know how to move your needles up and down to make sure you're in the right place. Because sometimes the way the head works, and the image is different. Your needle goes this way, but the image tells you the needle is different way. So you have to know when you're putting the needle, you're going in the right direction. You will not see that until you do it in real time. It's not easy to imagine. When you're doing it on a phantom, you start getting used to, you see the needle tip in the right direction. and you know where it is all the time. Once you can do that well, and then you can actually see people doing this procedure. If it's a young physician, I think some of them are available during their training, where they go through their specialty training programs, fellowship training programs. They can get exposed to these specialty programs. And then, but if it's somebody already established, then they can attend some of these specialized centers that does this. They will invite you, you come in, usually about a day and a half programs. So you actually see how it's done. In my case, like I said, I did it before it becomes available here. So I did it in Italy and I did it in Brazil. So, you know, you have more hands-on experience in those environments. And also because I've been doing FNA for more than 30 years, it was smooth for me to just learn the technique. So I think people, you know, simple staff know how to recognize all the difficult organs of the neck, and you do FNA very well. In other words, if you're not doing FNA in your practice, it's not, you can't just move to this. So it has to be, you already carve out some part of your practice for thyroid. Mm-hmm. So if you're doing that, then you can move on to more intervention areas of thyroidology, yes.
Are you a thyroid only endocrinologist, or do you do other forms of endocrinology as well?
I'm more thyroid in general, and I'm also known for that mostly, even before I started doing RFA, but I still do other forms of endocrinology. I do, I would say, thyroid almost 4 days a week, and I do intervention 2 days a week. 1 day a week, I do RFAs.
How many patients are you seeing for RFAs? Typically, you said maybe 1 day a week. So you see about 4 a month for RFAs? Sometimes
I do 4. You know, the demand is now there, you know, especially post-pandemic. Since December, we see the uptick there's no question about the demand, but because of the cost, people have to decide on whether they can actually come up with a cost. So we schedule in advance. So we kind of run between 2 to 4 a month. But in a day, I can do 2, 3, you know, depending on which was convenient for the patient. So because I blocked that day for RFA.
Do you do this independently, or do you have anyone else working with you on RFAs at your practice?
For me, yes, as an endocrinologist, I do it independent. Within my systems, you know, my affiliated system, there's some endocrine surgeons who are interested, you know, so we're talking about it. You know, we might collaborate.
That's excellent. Yeah, we're seeing a big growth in RFA prevalence. You know, in our Facebook group, we saw at least 100 providers this year are now offering RFA in the United States. And that's so exciting. And I'm so excited that you're having this collaboration with other physicians to do that. What sets your practice apart from other endocrinologists? You know, obviously RFA does, but what else can set your practice apart from other endocrinologists in the area?
We're kind of known for attention to details. You know, people send patients to me that they think need solution difficult, you know, second opinions. Take pride in that we try our best to individualize the care for what the patients want and what's the best for them. Of the experience and dedication to this field, you know, over the years. And they can call me anytime, you know, that if they have any, you know, I get calls, any difficult cases, they will always reach out to me.
I would imagine you're getting some referrals from your colleagues for RFA. Is that?
Yes, I am.
That's fantastic. What about the types of nodules that you're treating with RFA? Tell me a little bit about the sizes, and are you doing any kind of genetic testing to help determine who's a candidate?
Definitely has to be moderate to large. That means that you don't do it really for small nodules. Cosmetic score that is high, and with a symptomatic score that is high. And of course, you have to make sure it's benign nodules. That means that you make sure you do the biopsy and the cytology is benign. And like you said, if you do have indeterminate cytology, you can do the molecular studies and genetic studies to clarify that. Some patients come and they just want to go and do the RFA without making sure that we do those things. We're telling them that it has to be done for safety reasons, because if it's a malignant lesion, then surgery is best. As for now, we can discuss maybe for micro and low risk malignancy, which is being tried, especially in Europe and in South Korea. But that's a different discussion. But in general, there's that question of the ablation may not eradicate the whole cancer in after the ablation. So you have to really even if you're going to do it for the low risk cancer, the merit of that, we're discussing among ourselves right now to create guidance on that. But in general, you want to do the biopsy to make sure it's benign, and then it meets, like I said, symptomatic and cosmetic score, and the patient wants, and you both agree is the best option for them. And if you do that, you select the patient that is appropriate for the procedure, and you get desirable outcomes of significant reduction in the nodule, which is what the patient wants, without risk of surgery and the scar, which is really, and no need for medication. Again, those are the three main reasons why you want to do the procedure.
It is interesting to think about when you do the biopsy, that's going to also determine your strategy in treating that nodule, because if it is a small cancer and you are treating it with RFA, you're going to ablate more than just the nodule itself. You're going to have a little bit of the area around the nodule, and you wouldn't normally do that in a benign nodule, would you?
Absolutely. And the risk stratification is important, even if it is, like I said, in the cases that you mentioned, importantly, that you really want to know, because when you do RFA, it's different for benign and for low risk malignancy, because with low risk, you really go after those around it, because as much as possible. And number two, malignancy is different levels. There is high risk malignancy, which you will never do the RFA for, and there's low risk malignancy. So if a patient has very high risk malignancy based on stratification, the surgery is still the best treatment for that. So, and you don't want to not know that before you just do the procedure.
Exactly.
So I think educating the patients is very important, and if you do that, most people understand and they will make the right decision.
I think that it's helpful also for patients to understand that biopsies are really not that painful and not that risky or scary, but some patients are fearful.
And I tell them that actually give them an idea if we're going to do the RFA, what it's going to feel like. Even though, yes, we use more numbing medicine for the RFA, but at least you feel the movement. You kind of feel how you will be like when you're doing the RFA, and you feel comfortable. And actually, most patients, when you do RFA, they kind of do something. Most people just sleep a little bit, because they're comfortable and you numb it very well. Time you're in there a little bit, they're resting, and they don't really know until you call them and you ask them questions. It really is not a painful procedure. Most patients can tolerate very well without too much discomfort.
That's been our experience with patients in our group, is very, very infrequently do patients say this procedure was too much, I don't want to ever undergo it again. And typically those patients have some sort of issue that's, an underlying low pain threshold, or the nodule is in a bad location to be more sensitive. But most patients say, oh, just like you said, it was very comfortable, I fell asleep, or I was dozing. And that was my experience. I dozed off a few times during my procedure. I've had 2 RFAs because my nodule was very large, took little cat naps throughout. So the first procedure, even, he started ablating and then he said, how are you feeling? And I said, I didn't know you had even started.
Yes.
So it's very thorough numbing, as you said. I know we have a great deal of Canadian population in our Facebook group. Have you had any patients come to see you from Canada or from any other locations that are far away from New York?
I had one patient inquire. It was during the pandemic from actually Cuba. It was during the pandemic, and unfortunately, we couldn't really set it up. So I've had patients from outside the country inquire about it. Yes.
Yeah, we've got quite a few Canadians that are pretty upset that RFA is not available in their country. So
I can imagine.
Hopefully it'll make its way there. So let's talk a little bit about hot nodules. Have you treated hot nodules with RFA, and what's your experience been with that? Have you seen successes with normalizing TSH?
Yep. Actually, that's the one that also maybe not well recognized. That actually, I would say, that one is more, it will look like magic actually when you do that. You ablate the toxic nodule, the function goes to normal. Again, no need for medication, no need for surgery, and need for long-term treatment is gone. So far, the patients that I've treated are thyroid.
Have you had to treat any of them more than once, either for a hot nodule or for a larger size nodule?
No, this one is for a hot nodule. Not currently, no, not more than one. It's not a very big toxic nodule, so that's why it's perfect. Maybe close to 3 centimeter, 2.5, 3 centimeter, but it was toxic. And the patient wants it. instead of continue on medication and doesn't want RAI, doesn't want surgery, they say you're thyroid. So, but we keep following, but I'm not seeing any trend of the thyroid function towards the hypo. So it looks like it was a good ablated toxic nodule.
Well, that's exciting. What are some strategies that you have in place to help reduce complications from RFA? Because they do sometimes happen, but I know there's also some mitigation strategies that you might employ. So tell me a bit about that.
Number one is preparation. Like I said,
Yes.
I do what I call a marker for the nodules, almost like three-dimensional. Like I said, in geometry, you have to just picture what is behind, what is in the front, you know, where this, especially the posterior triangle. And I use it dextrose if I have to cool off, if I see symptoms of nerve damage or something like that, so that we can cool off that area. And I do dissection, you know, just to make sure we get enough fluids. So I have those ready, and my staff already know dextrose is available, and just like the lidocaine is available, you know, so everything will be set up, ready, drawn out. So I don't have to be doing it when I'm doing the procedure, when the complications happen.
Right.
It's already ready to just go. Of course, always check the voice box on ultrasound, make sure I see clearly on the ultrasound in the beginning, during the procedure. Like you mentioned, there is what we call aberrant anatomy, you know, which you will not be aware of, but at least you want to know where they are, because everybody doesn't have the same anatomy. So you can assume, oh, everybody, you know, so you have to assume like 4 or 5% of people will have an aberrant anatomy. The nerve may go through this way. Again, that's of a marking area for, if there's an aberrant anatomy here, the nodule is too much in that area, I will move away. So I ablate more of the safest area of the nodule. My experience is that if you ablate those areas very well, even though you do not touch some of the areas that is dangerous, the nodule will still shrink. So those, you know, preparation number one, and you put those to mitigation and be ready to intervene if you do have complications during the procedure. And post-procedure, observe the patient, make sure they're not on high-risk medication that can cause bleeding, and all that we make sure. Depending on the risk of the patient, an hour plus. I do it 24 hours, I do a tele just to see. They don't have to come in. I just want to see the site. I told them, of course, they can call me anytime, but I'll do that 24-hour check. And of course, then they come 1 week. We've been able to use those mitigation and planning to avoid any significant complications.
How many have you done so far since you started doing this in 2020?
Maybe we're getting to 20. Last month we did maybe 2.
That's great.
But the demand is there, like I said, people are asking.
Do you have any final thoughts you want to share before we wrap up about your RFA experiences or endocrinology or thyroid health in general?
The main thing is that we're having more innovation and advances in endocrinology in general, but also definitely in thyroidology. Even the ablation, even as we're doing it for thyroid, I think people are already thinking about doing it for adrenal, you know, other organs, doing procedure in a less invasive way and getting the same outcomes. Doesn't mean surgery is not going to be still there. We can do less surgery and minimal surgery or none at all if it's possible. There's more things to be done using intervention and innovation.